candidate COVID vaccines in the pipeline of development, ranging from preclinical studies through to licensed vaccines that we're discussing today. I think, just to orientate some background here, most of the COVID vaccine candidates are directed against generating an immune response to the spike protein, and particularly this section of the spike protein, which is called the receptor binding domain. And this is where really the virus interacts with host cells to gain access to those cells, because that's how viruses work. They need to get inside your host cells in order to cause problems. There are different platforms. Almost every kind of platform for vaccination is being employed in the strategy to develop successful COVID vaccines. And the two kind of ones that are most relevant to us in South Africa at the moment are these two. The first is what we call replication incompetent vector vaccines, and this is the adenovirus vectors that we're going to talk about today. What replication incompetence means is that they have the spike gene, and you can see in this pictogram, packaged into an adenovirus kind of cover. And this virus is replication incompetent, means that when it's injected into you, it doesn't replicate like a normal virus. It will get taken into the cells, and then that's it. The protein will be expressed by your cells, generate an immune response to both the adenovirus as well as the spike gene, which is the kind of trick of the vaccine. And then the adenovirus vector will disappear. This adenovirus vector technology is the basis of the J&J vaccine that we are rolling out in Sisonke, but also the AstraZeneca, or sometimes called Oxford vaccine, and then also the Russian developed vaccine Sputnik 5, as well as the Chinese CanSino vaccine. They all use similar but slightly different adenovirus vector technology. The other group of vaccines which have been really upscaled and at the moment form the majority of the doses of COVID vaccines given to date are these new technology of mRNA vaccines, where again, they have the DNA of the spike gene encapsulated within a lipid nanoparticle carrier. And the two that you might have heard about in the news are the BioNTech or Pfizer mRNA vaccine and the Moderna vaccine. One of the comments that I've seen a lot in the media is considerations or concerns around the rushed vaccine development. And what this diagram here really nicely illustrates is how there's traditional development of vaccines, and that goes from early preclinical data, usually in animals, so that's in both mice, and then sometimes usually progresses to non-human primates, and then through the phases of human clinical trials from phase 1 to phase 3, phase 1 being healthy volunteers, through to your larger population and numbers. Then after the phase 3 data is complete, that's when companies normally submit to regulatory bodies for approval. And then only once approval is in place do they roll out large-scale vaccines. That's the traditional model, which can take several years to implement. Now, I think the important part to note with COVID vaccine development is that no steps have been left out. They have just been compressed and performed in parallel. So many of the platforms, including adenovirus vector platforms, are found to combat other vaccines. So the J&J adenovirus vector vaccine, for instance, is found in vaccines for Ebola, for Zika, for several other viral illnesses. A lot of the preclinical existing animal data was already there for this vaccine technology. And then what happened is, in incredible scientific speed, they have these overlapping clinical trial development programs. And then the companies have taken a huge risk in producing or starting to manufacture these COVID vaccines already while they were still completing the phase 3 data. And then, of course, you've seen the rapid reviews, an incredible effort that regulatory bodies have had to get these improved. So there's no steps that have been missed. They've simply been compressed. And I think most safety data related to vaccine comes from these pre-licensure activities from phase 1 to phase 3. But I think what's important to note here is even an approved vaccine, and this is not just COVID vaccine, this is any vaccines, after they've gone through phase 3 data, may have seen usually thousands of volunteers. So in the order of 30 to 100,000 individuals may have received vaccination. But what's important to note there is that if you have a rare adverse reaction, a 1 in a million type of event, this is quite commonly missed in these phases of clinical trial development. So this is not like an error or where we've missed safety data. This is to be expected given the way that licensure for vaccines and safety data works. And so you can see here, this is now a nice figure from a recent Nature paper, which highlights the countries where the first 1 billion doses of COVID vaccines have been administered as of the 25th of April. What you can see here is when you talk about a couple of like tens or 100,000 patients, you can see that 1 billion is several fold higher to that. And this is the time that's called this post-marketing period where you're likely to detect these rare adverse drug events. So this is well known for vaccines. And so this is not, from a scientific perspective, unexpected. And I really think, in just 15 months, to have developed several vaccine candidates and have administered 1 billion doses is truly an unprecedented scientific achievement. Although certainly, there's several issues around vaccine access that could be improved, but this has been a huge effort globally. And in relationship to these rare adverse events, in fact, the first ones that really sparked up concern were these reports of anaphylaxis related to the rollout of the mRNA vaccines that I was talking about. And behind this is really the fact that, if you look at allergic reactions to vaccines, this is also, again, well recognized almost to all the common vaccines. If we think about childhood vaccines of diphtheria, tetanus, we think about pneumococcal vaccination, there are cases of anaphylaxis described to that. But normally, the frequency is about 1 in a million. And what we have seen with these mRNA technologies, again, and other new technologies, is that anaphylaxis events do occur, but they occur slightly more commonly, somewhere probably between 1 in 100,000 and 1 in 500,000. And again, so this was something that was not seen in the in the trials, the phase 3 data from these vaccines that only emerged in this post-marketing period. And again, this caused the vaccine community related to this to review this data, and there's been a lot of work around this to try and look at and understand the mechanisms behind that. And similarly, what we're talking about today has been these early reports and that have warranted these pauses, as Tian mentioned, where they've identified this rare clotting disorder in the context of both the J&J and the AstraZeneca adenovirus vector vaccines. But to understand these, we now need to understand a little bit about traditional clotting and traditional understandings of blood clots. So the first thing here is just the basic physiology of your blood clotting or blood flow system. And really what it is there are all these systems within the body to maintain the critical balance between maintaining your blood flow to transport valuable nutrients and oxygen around the body, and if you have a cut or minor injury, to prevent bleeding and loss of that blood. So that's what your blood coagulation system does. And just to take you through this figure, simply if you cut yourself, what happens is you get an injury to your blood vessel. You'll initially get what's called the platelet plug. So you get some platelets that get activated there that come to sort of form an immediate blockage. You then activate your cascade of clotting or your coagulation pathway, which generates a stable clot. And then what usually happens is that clot, there's some anti-clotting factors, or what we call fibrinolysis, which breaks down or hones the clot. And then after that, you'll get repair and healing of the vessel. So that would be a normal response to a physiological injury. What happens in thrombosis? Well, thrombosis as a definition would be an inappropriate activation of the blood clotting, and that can occur in usually intact vasculature or after minor injury. So this is an inappropriate or pathological clotting response. And to conceptualize this sort of scientifically or mechanistically, we usually use this thing called Virchow's triad, where we say that their abnormal clots can occur usually through kind of one of 3 processes or a combination thereof. So normally the first one would be the blood is going too slowly. So things that make your blood kind of slow and sludgy, that might be, for instance, immobility or being sort of sitting in a long car journey, that might put you at risk. Then there's things that might occur to the vessel wall or endothelial dysfunction. And we've heard a lot about that in terms of the pathology of COVID, of SARS-CoV virus itself, which has led to the very high incidence of clotting in the context of actual COVID illness. And then things that drive hypercoagulability, or things that change the clotting cascade that affect the balance of these factors, which then drive pathological clots. Now, normally, venous thromboembolisms arise from often multiple risk factors or the synergistic action of several of these things. And in our setting as well, we have in addition to some of these traditional factors that you might have heard about, like smoking or, proper thrombophilias or things like pregnancy or oral contraceptives. In addition to those well-known risk factors, we, in our context of South Africa, we also have known increases in coagulability associated with the infectious diseases such as HIV and TB. But these combinations of this are what give rise to the traditional presentation of a deep vein thrombosis or a pulmonary embolus, or for instance, in the context of arterial thrombus, perhaps a stroke. And there are other more traditional risk factors associated with atherosclerosis that also drive that. And if you look kind of at the fate of what can happen to a clot, well, it can either block the vessel, like occlusion, it can grow and worsen that, or it can embolize. Clots can break off, like from your leg, a DVT can break off and go to your lungs and give rise to a pulmonary embolus. And the clinical manifestations of clotting depend on where this has occurred, whether it's in the venous blood system or in the arterial system, and then where it's anatomically located. So your symptoms might depend on where it is. So if you have an embolism to the brain, that would manifest as a stroke. Whereas if you get a clot that breaks off and goes into your lungs, that's what we call a pulmonary embolus. And the clinical picture depends on that. But if you look at what the kind of traditional clinical picture and incidence of thrombosis is, what we normally see is that patients have a combination of risk factors. So those traditional risk factors that I mentioned 2 slides ago, they normally have a single site of clotting. So you might present with a deep vein thrombosis in your leg with leg swelling and pain over that leg. Or you might present sometimes with an isolated clot that's giving you a pulmonary embolus. So that usually comes from a deep vein thrombosis that breaks off and goes to the lung. You present with shortness of breath and chest pain. Or you might present with a stroke, but it's very rare that you would present with clotting in both an arterial and a venous system. And then the other thing is that for the most part, when we look at laboratory parameters, in people that present with a DVT, for instance, you'll often find normal platelets, normal fibrinogen, some of the markers of clotting that are normally, that you'll find to be normal, so they're not abnormal. And then in terms of frequency, well, actually in the background population, the prevalence of the incidence of deep vein thrombosis is very common. You see here 80 to 120 cases per 100,000 population per year. And similarly, pulmonary embolus can be as high as 80 cases per 100,000 per year. Now, what about this condition that we are seeing? Well, what happened was they noticed that there was a higher reporting rate of what we call cerebral venous sinus thrombosis. So now what that is that is a clot, an abnormal clot that's occurring in the venous drainage areas of your brain. Now, normally, unlike deep vein thrombosis that I mentioned on the previous slide, the incidence of cerebral venous sinus thrombosis in the general population is very low, sort of 0.2 to 0.4 cases per 100,000. And what they noticed was suddenly, oops, we're getting a lot of these cases now noticed, and that flagged up what we call a safety signal in the monitoring the various adverse event following immunization safety networks. And what's striking about this that they then noticed is that this looks very different from the previous traditional thrombosis that I've talked about in the previous slide. The first thing is the age group. So it tends to be in this 18 to 39 age group, and it's tended to be in women. So these 12 cases were the cases reported from the US and associated with the J&J vaccine. The other thing about it is they tended not to actually all have any traditional risk factors for cerebral venous sinus thrombosis. A couple of them had obesity, which is known to be a risk, and oral contraceptive use in only one patient. So you can see that they're different risk factors. The other thing, of course, is the temporal association to vaccination. It seemed to all be within 1 to 3 weeks after vaccine administration, where they presented with symptoms and then required hospitalization. Then the other thing is that they presented, in this case, because they were located in the brain, they presented with headaches, with back pain, associated systemic symptoms. And then the other striking thing about them is, in several cases, almost in 8 out of 12 cases, they didn't just have a clot in the cerebral venous sinus thrombosis. They had other signs of clotting in other systems. And you can see here, this was a clot in the portal vein, which is in your abdomen. And also this person had a pulmonary embolus as well. So the key thing here is multiple sites of clotting. Then lastly, from an immunological mechanistic point of view, all of these patients had low platelets. So this is in contrast to kind of the majority of patients with other thrombosis that have normal platelets. And then they had this antibody against what's called platelet factor 4. And this is like an activating antibody that causes your platelets to be more sensitive to clotting. So you can see here how this syndrome really looked like very distinct from your traditional understanding of clots. And then furthermore, after looking into this more detail, they noticed that sometimes you didn't just get cerebral venous sinus thrombosis. You could get multiple clottings in other systems without the brain involvement. But here, the same features are present. And this is what I've highlighted here with the red arrows. The timing in association to vaccination, the link and the association with low platelets, and then these multiple venous and arterial sites of clotting. So with all of that, what's happened is we've now come up from a safety point of view with a new draft case definition. So this is something called the Brighton Collaboration. The Brighton Collaboration is a group of global experts that look at ensuring vaccine safety, and they look at ensuring that there's good case definitions to study adverse events following vaccination. And so in line with all those clinical features that we've seen there, what they've shown here is that any patient with acute venous or arterial thrombosis and new onset thrombocytopenia, that's low platelets, and the count that they've given, just for a context for those that are not familiar with this, a normal platelet count would be above like 200, 250, up to 400, and so less than 150 clearly puts you in a low platelet category. And then patients need to have imaging studies to confirm the presence of thrombosis. And this you might pick up if it's in the leg and you're looking for a clot in the leg, you might use a Doppler ultrasound. If you were looking for a clot in the brain, like a cerebral venous sinus thrombosis, you might use an MRI. And they've called this syndrome thrombosis with thrombocytopenia. You might have heard, other terms that you've heard in the media might include vaccine-induced immune thrombotic thrombocytopenia, but that's obviously drawing a very close relationship to vaccines. And the reason for putting this separately is that one of the conditions that it appears to look most similar to is another drug-induced side effect called heparin-induced thrombosis and thrombocytopenia. So this looks like a very similar clinical picture and laboratory findings to that, which is a pathological and rare side effect related to the use of heparin anticoagulation. In terms of mechanism, well, it's still evolving. But I think what's important from a kind of general understanding is that the risk factors for this condition are not your traditional risk factors. So like pregnancy, oral contraceptives. So that does not put you at an increased risk for having this rare side effect. It seems like all of these very unusual immunological events that you probably need a series of problems to manifest with the event. So for instance, in particular patients, there might be an increased risk of direct platelet activation related to the adenovirus vector itself. There seems to be the presence, like in those 12 cases I presented, they all had positive anti-platelet factor 4 activating antibodies. And then there might be other immunological factors like neutrophil extracellular traps or abnormalities in adhesion molecules. So it's not going to be just one risk factor. It's going to be people that unfortunately have a series of risk factors that develop this serious condition. So just to put it in context now in terms of the incidence of this reaction. So this is a very reassuring recent review just published a few days ago, looking at the American J&J rollout of this vaccine. They've now given 8 million or just under 8 million doses, and they've had 15 events consistent with this thrombosis and thrombocytopenic syndrome. So that puts the overall risk of this at 0.2 cases per 100,000. So remember, that's in contrast to the background population risk of up to 120 cases of deep vein thrombosis and 80 cases of pulmonary embolus. So incredibly rare event. And based on this, most regulatory bodies and many governments as well have felt that the benefits of using this vaccine continue to significantly outweigh the risks. And as already been mentioned, the FDA has released the hold on this to allow rollout, and also from our regulatory purposes for Sisonke, we've also got the go-ahead and we've started revaccination. And then again, the last thing to think about this, and I think it's really important for those people considering risk-benefit in relationship to the disease itself. As I've mentioned, COVID, it's SARS-CoV, attacks the endothelium. And in fact, the risk of venous thromboembolism for severe COVID is as high as 14,000 cases per 100,000. And what's also concerning is this doesn't just affect venous sites. This seems to be risks of heart attack and strokes, arterial thrombus as well. And that might be as high as 3,000 cases per 100,000 in the ICU setting. So you can see here that there's a considerable risk of traditional thrombosis within the context of COVID itself. But I think that overall, for me, the benefits of the pause have been useful. And overall, in the long term, I think we will see that the public confidence to vaccines is improved by this. In terms of what's happened in this space of time, well, we've now developed strong, robust case definitions. We've had the chance to raise awareness of this condition in the public, to add necessary warnings and in strengthen in Sisonke, for instance, our protocol and our consent documents. And then also within the national framework to strengthen safety monitorings. There's specific treatment algorithms that have been developed, and I've listed the one here published from our own Thrombosis Society that are available in the South African Medical Journal for healthcare workers to look at. We've amended Sisonke protocols, and we've now improved robust information and materials. And here's an example here of some of the information that's out there where we now put on this warning. So just to wrap up there, the take-home messages for me is that there has been this identification of a rare serious adverse event to these adenovirus vaccines. And that's not unusual to find these rare events to all medicines in this post-marketing period. This is a very rare immune-mediated adverse event that occurs 1 to 3 weeks after vaccination with either the J&J or the AZ adenovector. And it's very different from traditional clotting and clotting risks. And the risk of thromboembolus events is much higher associated with severe COVID illness. And I think that needs to be considered. And then importantly for healthcare workers, the management of this is not the same as traditional clotting. And so there needs to be this awareness amongst publics and doctors. I'll end there. Thank you.
Thank you so much, Prof. A really in-depth overview, and I think you've really addressed many of the pressing questions and concerns that we as society have been really struggling with. It's been quite an experience, I must say, in the last few weeks trying to get messaging right. But I do know time is moving swiftly along. We have about 10, 15 questions, both via social media and in the chat box. But before we get to that, I would like to ask Prof. Linda Gail Bekker to give us an overview of where we currently are with Sisonke.
Thanks, Tian, and I'm going to keep it very brief as I see important questions. But thanks to Jonny also for sharing his insights. I did want to quickly cover what we've done specifically in Sisonke so people know. We are, as mentioned, really trying to flood the space with awareness. I think this is the most important thing. There are a few things we can do to screen people out. So the message is, if you're at risk of exposure to COVID, vaccinate, and beware of this very rare event. So, again, we don't want you to be worrying every day post-vaccination. We want you just to be aware, should it happen, that you seek help because it is imminently treatable. But it's important that we catch it early and you get into care as soon as possible. We're also educating our colleagues, people in the emergency rooms, etc., to be able to be on the lookout and to know how to treat this. So again, as Josh said, guidance really important for that. You only need to worry between sort of days 4 to 28. You are beyond those days post-vaccination. Hallelujah, move ahead, get on with your lives. Don't forget your NPIs, but you are absolutely safe. If you, within that period, don't spend your time worrying. This is a very rare event. Be aware. We are also, Sasonki, sending out 2 more SSs on day 7 and day 14, just to remind you that you do need to contact the safety if you have any of these symptoms. So that is another important intervention. And then strengthen safety desk and what we call the protocol safety review team. And people like me, Peters, has joined that now, and we have 3 hematologists, clinical hematologists on the team, all of whom have pledged individual attention. Should anybody go down with rare event, they will get hands-on support, or their practitioner will get hands-on support from our clinical hematologists. So those are just some of the things we've done. You will be aware that unfortunately SAHPRA required us to prevent pregnant women and lactating women from participating. They have said publicly they would review that. Today an amendment is going in saying, may we walk that back? And we are collecting the names of pregnant women who wish to be vaccinated so that we can revisit as soon as we have the approved on a new amendment. So that is happening. So we stopped on the 3rd of April. We convened, are revaccinating since the beginning of the week, as midway last week. We are heading towards the 500,000 mark. We're currently about 320,000 healthcare workers vaccinated, and we will do the full 500,000. So I'll stop there to receive questions, but just to say, vaccinate, vaccinate, vaccinate.
Thank you so much, Linda Gail. So colleagues, we'll get straight into the questions. I will just ask Linda Gail to have a look at her audio. You're coming across it slightly garbled from time to time. One of the questions we have from an anonymous attendee is, why was the study paused if the clots were so rare? I know you've touched on that a bit. If you could just give a brief reinforcement of your initial point, Prof. Peter.
Yeah, so I think that, again, in the context of post-marketing surveillance and identification of these rare events, I think it's the onus on regulatory bodies, on companies to, when there is a safety signal identified, you need to stop and get, like I said, it gives you this brief opportunity to really gather the case definition, 2, put the feelers out there in awareness for doctors that may have had an event like this to come forward and actually identify them. So you know, if you, for instance, if it's more common than you initially think, then often the pause allows you the time to see a whole lot more cases, and then it actually, you can review that. Then also it gives you time to think about mechanisms. And then I think once you've seen all that data, you can be more confident and come back to the public and say, look, this is what we're dealing with. It's a very rare event. Let's get going again. So, I mean, I think that it's like, to me, it really instills confidence in the whole vaccine program. And I think it indicates how seriously all these different bodies are taking it. And I think, to me, although it's, you know, you can discuss and argue that we've missed, you know, there's a risk of severe COVID and people are dying from COVID, and all those concerns are true. But also, like I mentioned in my first slide, given how long it normally takes for this vaccine process, we're actually been moving as a scientific community at unprecedented rates to get this going. And so I think, you know, I think a few days pause, in my opinion, is the wise choice. And I think it really, in the long term, underscores the safety and seriousness that safety is taken in the context of vaccination globally.
Yeah, thanks for that. I'm going to get into the next question, which you've touched on a little bit, Prof. Linda Gail Bekker. What happens if a person has a hemophilia condition, and very closely tied to that is, if I get vaccinated, what am I watching out for? What are the signs of a blood clot? Are there signs? How do I know?
Thanks, Tian. I'm hoping my voice is a little better now.
Much better.
If what you need to, so let me start with, are there any factors that would indicate you to be at greater risk of this, what we're terming VIT, or thrombocytopenic thrombosis that is related to vaccination? No, there does not appear to be any identifiers that would say, okay, we need to leave these folk out. Now, what Jonny has noted is that unusually it has mostly happened in younger people, and we have seen a preponderance of women. Having said that, it has occurred in men and it has occurred in older people. So again, very hard, although some countries have taken the decision to not offer J&J to young people. Those countries, as Tian has mentioned very wisely, have other alternatives. Where we have few alternatives, we may not have that luxury. So no, we are not able to identify risks at the moment. So the emphasis and the energy needs to go on post-vaccination awareness of symptoms. And what you might want to look out for is what we've identified, a few things so people can hang on to them. Headache seems to be a real feature. So a new onset, unremitting, unrelenting headache is very important to watch out for. Focal neurological signs is another one. Severe abdominal pain, again, unrelenting, new onset in that time phase you don't want to ignore. Also, heaviness in the leg, painful leg that feels like something you don't want to ignore, particularly if it's unprovoked, and shortness of breath. So that would be a DVT that is now embolized to the lung, resulting in a pulmonary embolus. I think I've covered most of them. Jonny, would you add anything else?
No, I think that's also, you've covered all the symptoms, but I think I would also highlight that even in flagging those, which is very important, even when you do that, the likelihood, given the available data, is that you will still have, like if you've got a DVT, that will still be related to traditional clotting risk factors. And, that's why the platelets, if you look at the algorithms, measuring the platelets is the next step. So definitely with those symptoms, seek medical attention. But even then, it's actually unlikely that the syndrome that you're having is this rare event.
Tian, if I may, I would just add, from what Jonny told us today, we vaccinated 340,000 people. We should have seen about 340 DVTs ordinarily in the normal everyday population. Now, we have seen some, and we definitely want people to let us know. So remember, our safety desk is collecting all adverse events. So we want to hear if you think you've had an event. But overwhelmingly, most of these, all of them, in fact, have had another cause or another reason for them. So everyday living type DVT.
Great. Thanks for that. And I'm going to, colleagues who are on the call, we will share, there is a number that has been set up to dial in. We will share that number in the chat as the call progresses. Linda Gail, if you could just quickly give us the English interpretation of focal neurological signs. Does my eyesight become blurry? Do I get black and white? What else?
Thank you. So yes, these big words. These are things that happen that are unexpected, that have to do with your neurology, okay? So with your eyesight or your ability to feel, your ability to use your muscles. So what you would expect maybe if you thought you were having a stroke, those kinds of things. So eyes deviating to the side, seizures, that you're not an epileptic and you have a seizure, or you suddenly get one limb not working as well as it should, or you don't feel a part of your body that you should normally feel. Those are the kinds of things we would want people to be very anxious about and seek help. As Jonny says, they might well be other medical conditions, but we want to hear about them so that we can intervene.
Absolutely, thank you. And I think, colleagues, the purpose of this webinar and so many others is really to ensure that while there's no platform to create alarm or undue alarm, we really want to ensure that communities and our partners have the information they need to remain confident in their decision to access a COVID-19 vaccine. Linda Gail, one question, it's a two-part question, which in a way Martha's leading me to think about. Martha's question in the chat box is, Canada is said to be holding back 300,000 Johnson & Johnson doses for an ingredient that is concerning. What is that about? But before you respond to that, if you could also, while responding to that, speak to the issues of how do we use this moment to bolster vaccine confidence and counter hesitancy? We've got Malawi with thousands of doses being discarded because of prevalent hesitancy. We've got Nigeria facing the same challenge. We've got parts of the US where people are just not accepting this vaccine. How do we navigate all of these little moments of learnings to build confidence amongst communities who are really overwhelmed?
Yeah, I think, Tian, maybe I'll tackle the second one first and see if Jonny wants to tackle ingredients in a moment. But the one that I really feel, very strongly about is this vaccine hesitancy. I mean, I would go down the road of saying vaccines get a heavy rap, and I'm not sure why. This wonderful innovation has saved millions and millions of lives and millions of ill health like polio and tetanus and diphtheria that not only killed people but caused terrible disability, etc. later on. So a very simple intervention but had an enormous public health benefit. Now, this is exactly what we are weighing up here as we discuss. COVID is a serious illness. It's robbed the world of millions of people already. And what we see happening in India is mind-blowing at the moment and heartbreaking. Now, we have in our disposal a vaccine, a simple 1 or 2 jabs that can prevent that happening. And that needs to be weighed up against the fact that it is a pharmaceutical. It does have a side effect. Now, again, it's up to us to make sure that that side effect risk never outweighs the benefit. And around the world, that has been looked at. As Jonny says, we stopped the world for a moment, stopped the bus. We said, let's review this, let's look at it. Overwhelming, every single agency that has looked at this has said the benefit of vaccination outweighs the risk in this setting. And so that's the message we have to get out to people is we are not doing this just for fun. We are doing this to prevent death and severe disease. And this simple intervention can do exactly that. But it's important that we get as many people vaccinated as possible because then the virus gets stopped. Not only do we stop death and disease in the individual, but we actually stop transmission in the community. And that becomes also very important as we try to manage these infectious diseases. We don't have smallpox today. We don't have polio today. Why? Because we have vaccination. And that is really a very important message to get out to people and in clear terms. So I think that is, the way to overcome vaccine hesitancy is to own where the risks are, but to explain the risk-benefit ratio concept, which we have to be patient about explaining to people and make sure we do it in ways that people can take it on board. The other thing to remember, Tian, and this is an important one, is the greatest risk to your life today is actually to get in a car and drive down the road or climb in a taxi and drive. Yet none of us debate about whether we're going to get in a car and drive down the road or get in a taxi and drive down in a taxi, right? We have to do it. It's got to happen. Life goes on. And that's exactly the risk-benefit ratio that we're talking about here. And there, the risk-benefit ratio actually becomes a lot closer than what we're talking about with this very rare event. So those kinds of analogies, I think, are also helpful. Jonny, I don't know if you want to tackle the ingredients question.
Yeah, I think the ingredients question is a good question, because I think, there's the first stage of vaccines, which is to develop a new vaccine. Then after that, in terms of rolling out and getting it to people, there are several steps that need to be looked at and need to be get right. So the vaccine now needs to be manufactured at scale, which involves making sure, when you make a viral vectored vaccine, you've got to grow it on different cells, or, the manufacturing process is quite tricky. And during that, things can change in the manufacturing. So if you look at all of the manufacturing facilities, they have very tight regulatory controls. They need to check vaccine, check that it doesn't contaminate it with anything else. And that whole process, then there's the cold chain. And, you've heard a lot about that, because different vaccines have got different requirements for that. Like, one of the tricky parts with the mRNA vaccines is the need for this -80 cold chain. And those things need to be managed all the way to the patient. And in fact, side effects can arise from the fact that you get a poor manufacturing problem or a cold chain problem. So the example that's been raised in this question around the Canadians holding back those 300,000 doses relates to the fact that those doses were manufactured in a Baltimore plant in the US that the FDA inspected, and then they subsequently put a hold on that plant, saying that there were, practices within that manufacturing facility that they did not approve of, that didn't meet their regulatory standards. So, that shouldn't call into question the whole vaccine. That calls into question a batch control for those particular things from that manufacturing facility. And we may well see that, and I think that's an important aspect.
So, Peter, sorry to interrupt. I think a question that would now be posed is just to give everyone peace of mind. Our Johnson & Johnson vaccine doses, are they coming from that facility?
No, the answer is no. They're not coming from that facility. And so, but I think what should give people confidence is to note that when manufacturing, this relates to the whole rollout nationally, independent of the trial, is to know that those processes are going on all the time to ensure that the quality of your vaccine getting to the person in your shoulder, that all those steps somebody's checking for. So that should bolster confidence even more,
Absolutely. And I think, as we even saw in the early days with the Oxford vaccine, when they paused, it's some of our messaging to communities was that this is a sign that the safeguards that are put in place are working, and they're working well. I'm going to move on to, I'll keep the big question in the chat for last, because it's pretty much an overall national question, when are we getting the vaccine? And really just speak to any top line messages specifically to pregnant women. There's been a lot of talk. SAPRA made an announcement. What is the situation with pregnant women as it relates to SAPRA?
So I'll pitch in and then hear Jonny's one. Pregnancy and COVID don't go together well. We know that there is additional risk to pregnant women and their unborn children if they get COVID. And so every agency I have looked at or read or gone to their recommendations around the world, including SASOG here in South Africa, the South African Obstetrics and Gynecology Group, have all come out in favor of vaccination. They have all come out to say pregnant women should absolutely line up. They have not been specific about which vaccine, very much recognizing that some countries do not have choice, that you should line up for a vaccine if you can. In terms of lactation, we have not been able to find risk for breastfeeding or lactation anywhere. And so that definitely, without doubt, we think that was an overcall. Frankly, on behalf of SAPRA, they have walked it back. We're getting the amendment in. So again, the recommendation is strongly in favor of vaccination. Jonny?
Yeah, I mean, I guess all I can say is that my wife was pregnant. I'd wanted to get a COVID vaccine. I mean, the reality is that, you know, pregnancy, as Linda Gail said, is a high risk for severe COVID. And so we have no safety signals around that. I think that, again, as you know, to reiterate the point that although traditional thrombosis is higher in pregnancy, so pregnancy is a risk factor for traditional clotting, it does not appear to be a risk factor for this rare immunological hematology syndrome. So my overriding opinion would be that we need to vaccinate to protect pregnant women and similarly breastfeeding women.
Peter, if you could just touch on these two questions because they linked very quickly, is would it be better to avoid vaccinating in the first trimester? So what I heard from you is that you should be vaccinated irrespective, but a question here from Jenny Nash, is it better to be vaccinated in the first trimester? And secondly, how many doses are needed to prevent reinfection? And is there a time factor? And have we even gotten to the reinfection discussion? So a quick comment on reinfection and when is the best time to vaccinate during pregnancy?
Yeah, I mean, I think that, you know, the risk benefit and availability need to be weighed up. In general, we like to avoid any medicines in the first trimester to be cautious. At the same time, I would say if you were a frontline health worker and you were exposed to COVID, then there's a real risk there and you shouldn't wait. If you get a vaccine, you should take it. I don't think, again, there are no safety signals across any stage in pregnancy. You know, obviously we like to, for some vaccines, like some of the most successful vaccine programs in pregnancy have occurred in the third trimester because there's an added advantage that you protect your neonate. So, you know, where a lot of pregnancy vaccine is focused on third trimester vaccines where actually the mom makes antibodies that protect the children. So that's like a little added bonus of vaccinating during that time. That's the first thing. Then the second question about reinfection, I think, you know, there's a lot of data emerging about reinfection rates, you know, from natural infection. So you do get reinfection and it tends to occur after 4 to 6 months from natural infections. But even then it appears to be at an incredibly low rate. So the, you know, sort of data of 0.7 to 1% risk in now quite considerably large healthcare worker populations. I don't think yet that we have sufficient data about, well, let's not call it, you know, reinfection after vaccination. So we don't know that, you know, if you've had natural infection and then you have a vaccine, how likely are you to get reinfected? I think probably exceptionally rare. But the question that we are trying to collect data from in Sisonke relates to COVID infection after vaccine. So, you know, we hope that from the phase 3 data, we are very likely that we're going to protect against severe disease. But what we don't know in the context of all the variants that are going around globally is, are we going to prevent infection? And if so, what's that going to look like? That's one of the main reasons and endpoints that we're looking at in Sisonke. I don't know if Linda Gail wants to add to that.
Great. I think, thank you so much for that, Prof. Peter. We are reaching the top of the hour. So I'll ask Linda Gail, could you give us a bit of an overview? Perhaps if you could touch on Bulelwa's question, which is, can the common symptoms of taking the vaccine cause the health of the older generation and frail to deteriorate even more? And once you've answered that, could you give us some kind of big picture thinking? Why is the rollout of vaccines going so slowly in South Africa? How can we as a country increase vaccination sites so general high-risk populations can get vaccinated too? I must admit, I've been frequently tempted to pop over to my home country of Zimbabwe to get my jab and come back. So over to you, Linda Gail.
I know, Tian, when Zim is beating us, that's, you know, it's when you get anxious. So, you know, sorry, and I've just forgotten what was the elderly. Very important that we protect the elderly, right? So the one major factor for bad outcomes of COVID has been age. I mean, age has been the biggest predictor of a poor COVID outcome. We've seen the worst morbidity and death amongst our elderly. And it is for that reason that many countries have started first in their nursing homes and in their over 80s and their over 70s to vaccinate. So, and similarly, in the J&J vaccine trial, of course, we pushed the age up. We said we're only going to enroll people over the age of 55 and 60, and we got a very good group of elderly people on that clinical trial. And we did not see any signals, safety signals, in the phase 3 trial between the placebo arm and the vaccinated group. So no, there does not seem to be any reason to worry that elderly will not do well with the vaccine. Now, what I would say is actually that the corollary of that is we often worry, take example flu, that it isn't going to perform as well in the elderly, because we know that, you know, when we turn 20, our immune system starts to take a nosedive, right? It starts to get old, it deteriorates along with the rest of us. And so we actually have a worry that we may not see the best performance in the more elderly. The good news again is that doesn't seem to be entirely the case, that we are seeing still a good performing vaccine that is preventing death up to 83% for J&J and 90% for the RNA vaccines. What might be a benefit for the elderly is they're not going to get that really robust reactogenicity that we see with younger people. So they're not going to get those really quite tough side effects that we expect day 1 to day 3, simply because they've got a slightly blunted immune system. What's my overall message here? Yes, it has gone too slowly. We absolutely all embrace that. There are multiple reasons I don't fully understand, many of them political, I think, where, you know, South Africa seems to have got on the bandwagon to get vaccines in country. Whether that is because we put all our eggs in the COVID basket, or whether we didn't start our bilateral, or whatever the discussions are, I don't know. What I do know is there's a worldwide shortage of vaccines. We are absolutely, sadly, in that band of low and middle income countries that are standing way back in the line, and we haven't been able to access our vaccines as quickly as we should have. We have looming ahead of us a wave 3. I don't know if that third wave is coming or not. What I do know is we need to, when we get these vaccines on board, deploy them as quickly as we can so that we are prepared for that third wave. And yes, it is a race against time. We may be lucky and avoid the third wave, in which case, great, we'll have more time to vaccinate, because it remains a threat around the world. COVID has not gone away. We have to prepare ourselves. So again, maybe my last message to everyone is, when a vaccine becomes available to you, do not hesitate. Jump. It doesn't matter which one it is. If it's licensed by SAHPRA in this country, it will be good enough. You need to jump and get your vaccination. Don't hedge your bets on this one.
Absolutely. Thank you so much, Prof. Linda Gail Bekker. Colleagues, in case there's anyone on the line with visual issues, that Sisonke safety desk number is 0800 014 956, and the website is www.sisonke.samrc.ac.za. Just a note that the African Alliance will also be putting out a range of communication tools targeted at communities around both blood clots, the pause, and where to from here. Colleagues, today we spoke to Associate Professor Jonny Peter, who's the unit head of the UCT Lung Institute, as well as Professor Linda Gail Bekker from the Desmond Tutu Health Foundation, who's also the co-lead investigator of the Sisonke trial. On behalf of ourselves and DTHF, thank you so much for spending your Tuesday afternoon with us. It's been a great discussion. Stay tuned to all of our social media platforms, and thank you again. And towards vaccinate, vaccinate, vaccinate. Thank you, everybody.
Afternoon, everyone.
Thanks, Tian. Great job. Thanks, Jonny.
Thanks.